Okay, we can get started. Good evening, everybody. My name's Eddie Arous. I'm a vascular surgeon. I work for the Vascular Care Group. We have a couple offices. We'll get into that a bit later. But thanks for coming. We're going to be talking about peripheral artery disease. So the topic of my talk is saving your limbs, understanding peripheral artery disease. I Thank you very much, Joanne, for helping me get sort of given sort of this platform to talk. I very much want to get questions, so we can. I think Joanne and I were saying we can save questions for the end. If you have questions, I don't know if there's a chat. You can type them in, and then we can address them at the end, so that way it doesn't get forgotten along the way.
Yep,
But
there is
yeah,
a chat line.
perfect. Yeah, throw into the chat, and then we can address it at the end.
And
Or
also too, one thing I forgot, Eddie, before I forget any further, disclosure, if you want to do a disclosure statement.
I have a disclosure slide. How about that? So,
Thank you for that. Thanks.
so I
All
am a
right.
consultant for a couple different companies. Doesn't have any relevance to our talk today. So my goal for today is to teach and essentially hope to understand the risk factors for development of peripheral arterial disease, determine the range of presentations for PAD, and understand the associated risk of leg amputation. Also, my hope is that we can understand the advances in treatment options for significant PAD, and we'll get into that. So what I'm going to reemphasize this repeatedly, is that PAD is very much a disease spectrum. It manifests as patients can be asymptomatic. They can have claudication, which is pain that occurs with activity, but is relieved with rest. And then the big differentiating factor between claudication and what's called chronic limb-threatening ischemia, called CLTI. It used to be called CLI, and the terminology changed a couple of years ago. So that involves pain occurring at rest or the presence of ulcers and tissue loss, and we'll get into that. So the reason this is so important is that really the vascular disease population is very much on the rise. The key factors that contribute to vascular disease are dramatically increasing. You see it in the patients that you take care of every day: frequency of obesity, diabetes, high blood pressure, as well as an aging population very much exacerbates these trends. Not only are patients have a high frequency of diabetes, they're living longer. And so we are treating patients honestly in their 90s or low hundreds even with this presentation. So is PAD common? So this was a study that's now 31 years old, from 1993, and it's at the time they were estimated about 10 million people in the country with PAD. Of those, half were asymptomatic, so 5 million. And only 1.25, so really only an eighth of those were really being treated. The big issue is the symptomatic untreated population, patients that are manifesting with claudication or limb loss risk, but are really not making their way to an appropriate provider to offer them a treatment. So who has PAD? So again, this is now a study that's almost 30 years old. But it showed that this may ultimately affect up to 12% to 25% of the population, and very much increased incidence with age. But you might notice that when they did the study, the average life expectancy of a man was 72. Things have changed quite considerably, and women are living essentially far longer. So really, what is the prevalence right now? And it's hard to tell. I would argue it's far more than 8 to 10%. So the reason this is so important is that patients diagnosed with PAD actually have an annual mortality that's higher than patients that have had history of a heart attack. So you are more likely to die if you have PAD than if you've had a heart attack. So these are the main risk factors. So you don't need to understand the chart too well, but really male gender, age, increased incidence every 10 years, diabetes, smoking, high blood pressure, high cholesterol. These are some blood levels, homocystinemia or C-reactive protein, race, and presence of kidney disease. So I don't know if you ever come across an odds ratio. So what an odds ratio refers to is that a male, for example, is 2 times more likely to present with PAD than a woman. And so these two on the right, they have the biggest odds ratio are diabetes and smoking, and they're going to be sort of repeated multiple times during today's talk. So if there's anything I can get you is to talk to your patients about smoking. I'm sure you're doing that already. So as I said, this is very much a disease in evolution. So asymptomatic to claudication, and then this big range of patients with chronic limb-threatening ischemia. So the analogy I give is that when you have claudication, which is termed to limp, it was derived actually from a Roman emperor who could only walk for a short distance. Then he'd have to stop and stand before he could walk again. It's relatively safe. Sorry, that's my daughter on the couch. So we can bring it over here. So, hold on. Okay, sorry, I have a 3-year-old on the couch. So it's overall relatively safe, but it can be debilitating to a lifestyle. So the analogy I give is that when you're exercising, the muscles in this patient's calf is not receiving enough blood flow to truly handle the exercise. So lactic acid builds up, pain occurs, then he has to stop, and eventually the blood gets there, so the pain washes away. The concern with chronic limb-threatening ischemia here is now there's not enough blood flow getting to the area at rest. So patients are presenting with ulcers, tissue loss, because there's really not enough oxygen to heal a wound that develops on their feet. So in terms of claudication, it's very important for us to distinguish someone's leg pain as really being vascular claudication versus alternate etiologies. So typically it's associated with cramping, tightness, aching pain, more commonly in the buttock, the hip, the thigh, in muscle groups, really not bony pain, just muscle-induced pain. It's associated with exercise. It has a consistent distance. Patients may say, I can walk a quarter of a block and then I have to stop. They should feel better when they stand because now you have gravity's assistance to bring blood flow down. So they may have to stop for a little bit and then the pain will subside and then they can walk an additional distance. So CLTI is different. This is a rest pain, is pain that occurs whether the patients are walking or not. Includes pain that occurs at night. You might find that your patients are sleeping in a recliner, specifically so that their legs are in a dependent position, or they might sleep with that affected leg hanging off the bed. And then, of course, I mentioned the presence of ulcers or non-healing wounds and ultimately gangrene. The reason this is so important is that if someone presents with CLTI, they have a significant risk within 6 months, they have a 1 in 5 chance of dying. They have a 40% chance of losing their limb and a 40% chance of being alive with their limb. So essentially, only 40% of these patients are alive with their limb at 6 months. So the diagnosis is really crucial. There's really no detail too small. It's important for these patients to get a physical examination. Common signs of PAD are cold lower extremities. You might notice sort of absent hair loss on the affected leg or foot. They might have poor nail growth or dry, scaly skin. The picture I put here on the top right is a demonstration of what's called dependent rubor and elevation pallor. So this is commonly confused with cellulitis, where a patient might have a red foot, but it's only red when their leg is in a dependent position, when their leg is down. The analogy I give is that their blood vessels in their leg are so starved for oxygen, they're all very vasodilated. So any blood that gets down to the foot is going to give their skin a ruberous appearance. So if I elevated this leg above the patient's heart, it would turn white. Then I commonly put the leg down, have them sit off the edges of the bed, and we'll watch over the next 20 to 30 seconds as the extremity turns red once again. And of course, the presence of tissue ulcers or gangrene. In terms of location, PAD ulcers typically occur at the furthest part of the body. So toes, bottom of the toes, so the distal extremities. So how can you test for PAD? Really, this should be done with a non-invasive way, ultrasound. So ankle brachial index, an ABI that uses a Doppler. You can do a duplex, which is sort of an ultrasound sort of examining the blood vessels themselves, or a treadmill study where you sort of walk the patient until they experience symptoms and you would obtain an ABI before and after the treadmill test. So this is hopefully many of you have done, but how to measure an ankle brachial index. So the way we obtain it is you put a brachial cuff on each arm and you measure the systolic occlusion pressure. So what is their blood pressure, top number, the systolic number on each arm? You take the highest number. Then you put the same blood pressure cuff down at their ankle. And again, now you're going to listen over the dorsalis pedis and find out what pressure did the signal go away, and repeat for the posterior tibial. So you take the higher of the two between the DP and the PT on each foot, and you make that the numerator and use the higher brachial number. So if the blood pressure in the arm is 120 on the right and 150 on the left, you use 150. See that now? So if you are on the dorsalis pedis is 150 and the PT is 120, you use the 150, use the higher number for each. So Typically, a patient's symptoms is very much correlated to their ABI. So a normal ABI is 0.9 to 1.2. I give these to patients in percentages. I say your foot is getting 90 to 120% of the blood flow that your arm is getting. And it should inevitably be a little bit higher than 1 because your legs are just due to gravity, sort of more dependent than where your arms are. Typically, patients with claudication will have an ABI between 0.7 and 0.9. Rest pain is 0.4 to 0.7, and then ulcer is less than 0.4. This non-compressible number of 1.2 is a representation of someone who has calcified vessels. So if the blood vessels are so calcified that no matter what blood pressure you raise the cuff to, you can never get the pulse to stop, then you really can't get an accurate measurement. That's more common in someone with diabetes or kidney disease. So this is a representation of something we call segmental pressures. I'm sorry, it's a little bit blurry. So this is an advanced ABI, where on here, on the cursor here, so I don't know if the cursor is carrying over, but so they have really a bunch of different blood pressure cuffs. So here's one of the high thigh, the low thigh, the upper calf, the low calf. They have one at the metatarsals, and then even a little toe cuff. So in this patient, there was a brachial pressure of, this is 131 on the right, 129 on the left. So you use the 131 number. And then you'd go down and the PT looks like they got 113. So this side would be 113 divided by 131, which I hope is 0.9. And then on this side, looks like they got a number of 128. So 100, or so maybe it's 138 over 131, even though it's the opposite arm, they got a number of 1.11. So there was more disease on the right than on the left. The other thing that this multi-segmental cuff method gives us is that it allows me to get an idea of where the blockage really is. So if I go around, I see here the high thigh pressure was 128, but the low thigh pressure was 102. It really tells me that somewhere in the thigh, there's likely the source of the blockage. That's likely where the lesion is within the superficial femoral artery, one of the most common spots. The last thing is that these cuffs actually have a sensor that it's called pulse volume waveform. So it actually characterizes the volume of your limb with each heartbeat. So if you realize, but every heartbeat, your limb expands and then contracts just due to volume of systole and diastole. So you can obtain these volume recordings to determine what is the volume of blood. And it becomes more, you might notice on this patient's right side, it became more blunted down below, suggestive of a lesion upstream. So I mentioned these little blood pressure cuffs on the toes. So this is a zoomed in sort of toe pressure. So in this patient, toe pressures are valuable if the patient has non-compressible ABIs. When I gave the analogy of no matter how high you inflate the blood pressure cuff. So I tell patients to think of it like a PVC pipe. These patients will have sort of PVC pipes going down towards their feet. So no matter how high you inflate that cuff, it's never going to stop the blood flow to the foot. So use these toe cuffs. The digital vessels in the toes are usually spared of that calcium, of that PVC type pathology. And here you get a measurement. So this patient has a TBI of 0.47 on the right, 0.44 on the left. This is only done in a dedicated vascular lab. So typically a TBI of 0.7 or more is considered normal. And then if you have a pressure that's less than 30, these are patients that are at risk for non-healing of a toe ulcer or a foot ulcer. So if I have a patient that's a diabetic or on dialysis, I will order ABIs with a reflex TBI. I do see a chat. Maybe I can do chat as we go. Let's see. So detection is key. So really, when I brought up the point of those patients that are symptomatic untreated, the reason this is so crucial is that this is a study that's more recent, sort of the early 2000s, 2003 to 2006, and looked at all patients, about 20,000 patients over this 4-year span that had a major limb amputation. I mean, they all had a BKA, a below knee, or an above knee amputation. And 54% of them, over half, didn't have any intervention, meaning they either presented too late or they were in an area of a country where they didn't have a vascular surgeon or someone that was sort of able to improve the blood flow. This is what it's so critical to sort of to detect or identify these patients early on, because many of these can be prevented. So what happens next if someone has a low ABI or a low TBI? How do we address it? So really now that falls sort of onto the specialist to determine what is the appropriate imaging. So there's a variety of tests. We can do a duplex ultrasound, which we do in our vascular labs or in the office, a CT angiogram, which is pictured here, so a CAT scan-based angiogram with IV dye, an MRA, an MRI angiogram, and then an invasive angiogram. So an invasive angiogram is something that we do in the office. Some places do it in the hospital. We do it in the office as well. Many would say the advantage of an angiogram is that it's not only diagnostic, but it's potentially therapeutic, meaning while I'm in there, I can treat the area with a stent. So for example, hopefully my cursor shows up here, you might notice this little shepherd's hook here. This is in the abdominal aorta. So if you trace this down, this is coming down from the right leg. So this procedure, let's put an IV in the right femoral artery and work their way up to shoot the picture here. So if you look down, what about the left leg? I sort of see this little string sign or very little perfusion getting through this area of the common iliac artery going to the left. So if this patient was potentially presenting with left leg claudication, at the same time, I could then access the left side and stent this area. And they'd feel relief immediately. And after the procedure is done, they'd go home, they would sort of notice that their symptoms have resolved. But the other advantages here is that you might notice that these are the kidney arteries, this is the right kidney and the left kidney. There is a very significant blockage going to the right kidney, even a moderate blockage going to the left kidney. Not saying we'd fix these all at the same time, but it gives me sort of additional information about really what the patient might benefit from. So if this patient really was a multi-drug resistant hypertensive, this might be someone I would talk to the nephrologist, say, hey, while I was doing the angiogram, I noticed that they have very significant bilateral renal artery stenosis, and it might be worthwhile treating those blocks to see if their blood pressure improves. So the treatment options for claudication, rest pain, and gangrene vary considerably. And the point of this slide is really to show that all patients should be screened for, make sure they're on the proper medical management. They also be considered for minimally invasive as well as surgical treatments. So I'm going to start with medical management. Really, it's valuable at all stages of PAT presentation, including those that are asymptomatic. Those are the ones that I have frequent discussions with. So, I don't have any leg pain. My ABI is 0.8, but do I really need to be on a statin? And so lifestyle modification is first. Exercise. So there have been multiple studies about demonstrating appropriate exercise therapy for a patient with PAD improves their overall walking distance. So we typically recommend 30 minutes of walking 5 days a week. Patients can usually double their overall walking distance. And the analogy I give is that patients are now training their muscles to tolerate a lower oxygen level, or think of it as the main road or the highway down to their feet is blocked, and you're just sort of promoting development of the side roads or the collateral blood vessels. Smoking cessation. The reason this is so important is that treatment in an active smoker, a stent or a bypass, has a significant reduction in the overall patency. So they're less durable in someone who's smoking after intervention. Many patients, if they quit smoking, may find that their claudication resolves or they're able to sort of walk considerably further and may not need any intervention. In terms of diet, I select about a cardiac protective diet, so not identical to what your cardiologists recommend. Risk factor modifications. So I showed all those risk factors of high blood pressure, so make sure they're on the proper blood pressure control, their diabetes is well controlled, checking their most recent A1C, and then is their cholesterol under control as well. So for medications, all patients would be on an antiplatelet. We put them all on aspirin 81. There's really no studies on the PAD literature about doing full dose aspirin versus 81, so 81 is sufficient. If they're not on it, and obviously some patients come and say, oh, I don't need to be on it, or I heard on the newspaper that I don't need to be on aspirin anymore. I then educate them and say that population is actually different than you. Those patients did not have documented PAD. And so I don't have a slide for this, but the reason it's so important that we put patients on aspirin and statin is that there was a study in the 80s, it was done at the Cleveland Clinic, and you actually can't do the study anymore, but any patient, they took 2,000 patients that had PAD and they all got a heart catheterization. So every single one went to the cath lab and they shot dye into the coronaries, and 25% of them had CAD, coronary artery disease. So really these medications are not just meant to reduce the risk of progression from PAD, but really for heart health. Really don't want them to sort of now have undiagnosed CAD, coronary disease, that was not treated. So all patients should be on a statin. Honestly, the dose doesn't matter. We put them all on a statin, and I'll go based on what their LDL is, and I'll titrate with their PCP. Now, the most recent studies have demonstrated effectiveness for rivaroxaban, Xarelto, for PAD. So there was two studies that came out, the Voyager and the Compass trial. Those are 2022, 2021, that showed if you had patients that were on low-dose aspirin 81, in addition to low-dose rivaroxaban, they had improved cardiovascular events. So now the general tendency is to also consider putting them on low-dose rivaroxaban. So if you have patients that are on rivaroxaban for DVT, you might know they're on 20 milligrams daily. Usually start at 15 twice a day, but they're on 20 milligrams daily long term. The PAD dose is actually pretty low. It's 2.5 twice a day. So really if someone says, so they're getting 5 in total per day. So a quarter of the dose of the standard rivaroxaban has been shown to be beneficial. So smoke cessation is the most important to determine outcomes of patients with claudication. If they are presenting with claudication, they quit smoking, they're very unlikely to progress to rest pain or CLTI. I understand this is easier said than done, but this is honestly the first thing, numerous referrals to the QuitWorks hotline or anything, any way to sort of assist. I spoke about exercise. So this is a study that demonstrated that patients' overall walking distance doubled if they were able to exercise at the time of diagnosis. So even while smoking, if they exercise, they were able to walk twice as far at 6 months and maintain that distance at 18 months. So this is a bit of a, going back again to that pie chart, but overall, this CLTI is sort of a dire natural history, 40% rate of limb loss at 6 months, 20% rate of mortality at 6 months, and only 40% are alive with both of their limbs. So ultimately, the rate of limb salvage is very much dependent upon revascularization. So patients with rest pain, so pain that occurs at rest, 27% of them are able to keep their limb with treatment. So as tissue loss, really only 5%. So it's really important to identify these patients. The other thing that's important for us as treatment providers is that we've understood that their amputation rate is very much dependent upon their presenting ABI. So if your ABI is less than 0.5, so 50% or less blood flow going out to the leg, the amputation rate is nearly double, so 15 to 34%. So why is it so important to fix patients with PAD? And really, there's so many chronic problems with patients with ulcers, et cetera. Wound care, wound dressing, sort of arranging sort of home visits and who's going to be able to manage their wound at home, pain requirements, limited ambulation. Patients will lose their independence and lose their autonomy. Where are they living? Is there 2 floors? How many stairs? Can they move to a facility? Do they have family that's going to be able to help them at home? And as you are all aware, they have a much higher rate of recurrent hospitalizations after a major limb amputation. So having one leg amputated gives you about a 50% risk of death at baseline. So once you have a major amputation, you have 50% risk of death within 2 years. So really my goal, or all our procedural goals, are to relieve pain, heal their wounds, ideally preserve a functional limb, maintain their ambulation and independence, and now through additional measures, we're looking to minimize the risk of mortality and major cardiovascular events. But overall, this is sort of a complex decision-making process. So really, this is done with not just a vascular clinician, but also the longitudinal care team, their PCP, their home nurses, their sort of facility. It's also to identify what is the best treatment. So this is a bit repetitive, but sort of statins, diabetes control, hypertension, nutritional counseling, antiplatelet therapy, and smoking cessation. So as a surgeon, my goal here is to restore pulsatile blood flow to the foot. And so in terms of treatment methods, there's really 2 ways. Endovascular therapy, which is done with catheters and wires to manipulate, or bypass surgery, which is sort of more timeless surgery. I'll get into that. And the choice really depends upon the patient's medical risk due to their comorbidities, the anatomy of the disease, where the blockages are, and do they have conduit? Conduit meaning the method to connect or get around the blockage. And that really depends upon, do they have autogenous vein? Do they have saphenous vein to use? So in these patients, I'm going to show a bit of an example moving forward, but the anatomy very much determines the treatment option. So typically, a smoker will have blockages from the aorta to the popliteal artery. So basically from the belly button to the knee. Diabetics or patients with kidney disease typically have blockages from the knee down towards the foot. So this is someone, top picture here, the right iliac, this is the right side, looks perfectly normal, but there's a complete obstruction on the left side. This would be a very challenging treatment with the stent. This is likely someone that's going to be pushed towards surgery. Similar here on the bottom right, this is a femoral artery. You might notice this is the outline of the femur and sort of going down to the patella. Sort of the contrast dye is black, and all the lumpy, bumpy white is all the calcium and cholesterol. This could really go either way between a balloon or a stent. And then down here, this is likely someone, this is below the knee. This is the tibia and the fibula. So the blockages all appear to be below the knee, sort of from the popliteal artery going down. So this is someone I can identify just from the angiogram. This is probably a diabetic. So surgical bypass. So let me say this is timeless surgery. This is how it was all done before endovascular techniques came back. This is a picture here of someone with a saphenous vein graft. So a vein that was taken and sewed to the common femoral artery and the popliteal artery as a way to get around the occlusion or the blockage in the superficial femoral artery. So you're bypassing around the blockage. So as big incisions, this is sort of a classic example of our patients. We would not only make incisions to expose the arteries, but also to take out the vein. Now, in these pictures on the left, these are PTFE. So this is polytetrafluoroethylene. So think of that as Gore-Tex. So these are Gore-Tex bypasses where this patient likely would have no vein. Maybe the vein was taken or the vein was just too small or inadequate or had previous clot. And then the advantage of that is that sometimes you can do sort of extra anatomic bypass. This is a fem-fem bypass, a right femoral to left femoral bypass. So it's called extra anatomic because it's not normal to have a connection between your two femoral arteries. But this is the treatment method for that patient. So beginning in sort of the late 1990s, early 2000s, really the trends in PAD therapy have gone considerably in the endovascular front, catheter-based treatments. So overall, the number of lower extremity revascularizations has gone up over these 20 years, but the rate of catheter-based treatments is the main driver for that. So an endovascular option is really based upon the ability to navigate a wire across the blockage. So in this simple diagram, so this is the cholesterol or the plaque that has built up within the artery. Once you're able to navigate across the blockage, there's a whole myriad of things you can do. And there's a bunch of devices to help you do that. So in my end, there's all these different catheters, have all different shapes, sort of help you get across different blockages. And really, these are very small. And then from there, a variety of sort of devices to help debulk the plaque. This is sort of working to try to chew up the plaque. And this is something called a re-entry device to help you get around it. And then really now, even still, there's so many more advances in terms of stents that have drug on them. So these are chemotherapy type drugs, just like you'd see for heart stents, sirolimus based. There's drug-coated balloons. And then there's even newer things about sort of stents, sort of tibial stents, sort of stents in the lower part of the leg. And the advances are honestly occurring every year. So this is an example of something I mentioned called a re-entry device. So typically, what we would try to do is get in this picture B, this wire, we usually try to get right through the cholesterol blockage and treat it. But sometimes it's not feasible. Sometimes you are forced, if this blockage is so significant, to go between the layers of the artery. So the artery has three layers, sort of intima, media, and adventitious. So think of it as like a three-layered sandwich. So the block is blocking sort of the main pipe. So if you're able to go between the inside and the middle layers, now, as long as you can pop back into the main channel called the true lumen, which this device helps you, now I'm in the main lumen here and the main lumen here. If I put a stent to connect these two blockages, it will eliminate or basically push this blockage to the side. And there's so many different types of stents. This is sort of a bare metal stent. These are sort of stent grafts, which is stent with Gore-Tex mounted to it. And there's various reasons why you do that. So this, I'm going to take you through a couple presentations of what we could do. This is a patient with aortoiliac disease. So this is the aorta and the iliacs, and you might notice that the black, now mom is downstairs, you want to go down? So the blockages go from the iliacs down to the groin. So in this scenario, I'm able to sort of navigate a catheter. I'm not just this little black thing here by my cursor, or the red circle, and I'm able to get through it. And then the same thing's occurring on the other side. So once I can get through that blockage, I simply just deploy a stent. to fix it. So these are pictures of the stent extending from the aorta down towards the right groin. And then the similar process was done on the left. This is maybe an easier picture to sort of demonstrate. This is sort of a femoral popliteal blockage. So patients with blockages in the femoral artery in the thigh. So here's a device going down to the femoral artery. And you notice that here the blockage, there's no black here. There's just sort of collaterals and then filling into the artery down below. So if I'm able to navigate a wire and connect these two, now the possibilities are endless. And so now I'm able to restore blood flow through that. You might notice all of these little collaterals are no longer present because the blood is preferentially going down this way. So in essence, I want to sort of demonstrate that PAD is highly prevalent. It's oftentimes undiagnosed or misdiagnosed. And the diagnostic testing is easy, it's non-invasive, and it's available in the office. And really, the treatments that we can do are done in the office. So what's new in 2024? What's changed in PAD? We've been talking about just going down to the 1980s. So really, COVID had a big impact. And so patients are far more interested now in having their service or their treatments performed in an office setting, and that's how we deliver care. This was very much the paradigm outside of New England, very common in other states, but in New England, there's such large hospital and healthcare systems, patients typically would be going to the hospital to get this setting and stay either overnight or be monitored for 6-8 hours post-procedure. So the benefit of COVID is that now patients are more interested in having the procedure all done in the office. There's multiple benefits for that. So this is sort of an office or outpatient-based laboratory in New Massachusetts. This really started in 2008. This is when Medicare sort of allowed for these patients to receive their vascular procedures in an outpatient setting, and it's benefits to all parties, patients, providers, and the payers. I really do believe this is sort of the way that vascular care is going to be delivered. So these are offices that we provide. So I work in Worcester. I have an office, a satellite office in Sturbridge. We really have offices sort of all over Massachusetts, office in Connecticut, and a new office that opened in Portland, Maine. But so the benefits for a patient. So patients really just receive truly patient-centered care. It's ease of access. They receive all their testing in one location. So I give the analogy of it's like going to the dentist. You sort of show up at our office, you get evaluated by the surgeon. You then have an ultrasound done in the office if necessary and say, okay, well, let's proceed with the stent in your left leg. You get a date and time, you go home, and you return to the office a week or so later for your procedure. You park in the parking lot, someone's driving you home, and after the procedure, you're usually gone within 30 minutes to an hour. This sort of patients receive fast points, specialized attention. The same nurse that will call you the day before for instructions is the same nurse that's going to check you in, do the procedure with you, give you the instructions to go home, and call you the next day. And really, patients find it beneficial because they don't want to go to the hospital. There's risks of hospital-acquired infections. They don't want to sort of figure out where to park. And it's much easier for patients. We can deliver care close to home. With all of our offices over the state, this is the intention. We can sort of partner with smaller hospitals to deliver care rather than having to go to Boston or downtown Worcester for all their care. Our patient satisfaction scores are accordingly sort of above national averages, as we would expect. So in terms of the physician, it's beneficial for me too. I find my life, my sort of care for patients to be much more productive. I have better efficiency. I can control my own schedule. So patients have I have a better lifestyle this way. I feel better about the work I do. Sort of vascular world, the big concern about burnout because patients are being drawn out. But I really feel like I could do more passionate care. And I do think I'm doing what's right for the healthcare system with cheaper expenses. So it's also beneficial to insurances. So insurances are very much a fan of sort of doing procedures in the office. On average, procedure costs 30 to 50% less. The stent done in the hospital oftentimes can cost up to $30,000. Done in the office, it's about $10,000 to $12,000. It's monumental. Patients aren't presented to the hospital with complications, which sort of saves costs and overall saves millions of dollars to already sort of taxed government programs. So these are how we're able to sort of deliver care to patients in the community. Patient visits, all the diagnostics, procedures, wound care. And we still partner closely with hospitals. 50% of the procedures that I do are in the hospital, if necessary. These are all the hospitals that we sort of coordinate with. And we provide 24/7 call services for these hospitals. We have physicians sort of in leadership positions, but we sort of have physicians on staff at all these hospitals all over the state. So I want to thank you very much for the opportunity to talk, and I'm hoping to sort of answer some questions about PAD.